What is really key when we think about healthcare in general is the idea of basically having data sharing and having these different systems be able to talk to each other. One of the things that I think is key as you see more innovation happening at the state level, that we sort of don't create states as their own fiefdom, if you will, and we actually connect the states. So when you talk about data exchange and you talk about systems that talk to each other, I think that is absolutely vital. And I have some concerns that that's not happening. If you look at healthcare in general and you compare it to other areas of industry, just look at the social media side and Google, the Yahoos of the world. I mean, what they're doing is so sophisticated. We need to bring that same sophistication to healthcare in terms of data, but what we don't want to do is we won't want to create individual state fiefdoms like we've done in the insurance market. We want to be able to communicate across all states. When we think about quality measures, this is a concern that I have from a couple of standpoints. First of all, from the standpoint of CMMI, I really think quality measures should be driven from the provider side, heavy input with the payers, and more heavy input, even if you will, from the patient side. So what I'm concerned about as we start thinking about quality measures at the federal level, that they're relevant, because a lot of quality measures that have come out from the federal side are not relevant. So now all of a sudden, when you have state programs and state innovative programs, you don't want to have different quality measures across different states. So we've got to get our act together here in terms of, especially when I think of my area in terms of oncology, we have to have open measured, agreed upon measures, and whether that's implemented in the programs that are implemented at the state level or at the federal level, that we're all using the same measures.
The desire of Medicare, specifically CMMI, to develop models that are easily adaptable to the commercial payer market, I think has been embraced by the commercial payers. And so Aetna, for example, has made a firm commitment towards the concept of promoting accountable integrated care. We have relationships with a lot of provider systems around ACO models. I think that it's not always so easy to do exactly what Medicare does, but to the extent that we've been able to make them at least occur in parallel, they've been somewhat successful. That's not to say we're anywhere near the end game here, and of course Medicare has very aggressive projections about how many patients they want to have in alternative payment schemes over the next couple of years. I'm not sure that the commercial world will be quite as ready, but we are definitely moving in that direction.
One of the issues that I have in terms of when you think about some of the models that have come out of the ACA healthcare reform, obviously one of the biggest ones is the ACO model and several different variations of ACOs that are being implemented. I think on the surface, some of those are really good models, but the problem is the implementation. I think there are a lot of problems on the implementation side that we've seen it. We've seen a lot of for example, the providers that are in the Pioneer ACO models drop out. And I think we have problems and issues that we have to deal with. So I think there's a lot of good start and head start in terms of innovation, but I think that especially with some of the ACO models, we have some basic fundamental problems.
So the quality measures that that are part of the Medicare ACOs, for example, as an oncologist, I don't think they have very much bearing on what constitutes quality care in oncology. I mean, if you look at the quality metrics that they have, I'm quite comfortable with the idea of cost of care type metrics. But most of the oncology metrics are around screening, for example, which at least, from a population management perspective are important metrics. I'm pretty sure that as we see evolution of these integrated models from, let's say, predominantly a primary care model to a model that accounts for specialty care, because let's face it, that's where the real opportunity is, we will see some evolution of what are really appropriate quality metrics that will go along with this expansion of the integrated delivery model.
One of the issues that I think we have to really grapple with is if you look at a lot of the innovation models that are coming out on the ACO side and elsewhere, is the quality measures. So for example, when ACOs were launched by Medicare and they had 33 quality measures, not one of those measures has to deal with cancer care. Two of the measures actually have to do with cancer, but it's literally more the early diagnosis on the colorectal side and also on the breast side. But none of them do deal with routine cancer care. So it's very difficult when you have mandated measures, for example, an ACO, but you have nothing to judge how oncology or oncology practices are doing. So I think we've got a lot more work there, and I believe that what we have to do is we have to have more of the providers involved with heavy patient, not having the federal government dictate the quality measures.